Good morning, friends. Let me thank Lily and Diabetes. Is that okay? Right. Uh, as judges just mentioned, the first talk is going to be about understanding the chronic nature of obesity. Now, we've always thought that obesity is a stage po jaiye. Okay. We've always thought that obesity is a cosmetic problem. And so what you need to do is just get rid of those extra kilograms and start looking smart in your outfits. Well, obesity is a chronic, complex, multifactorial disease complex, and we are going to enumerate more adjectives to that. But remember that weight regain with obesity, once you lose weight, weight regain is a huge problem. And therefore, we need to really adopt a chronic care model to diabetes care. And that's what exactly Jajji said in his opening remarks. So in the next 20 minutes or so, what we are going to do is to talk about the salient features of obesity, see its repercussions on health, and then see what are new management strategies that we have in hand. All the speakers in this program are contracted by Lilly for this symposium. And as he mentioned, please talk only on-label questions. We just answer those. Lilly expects that we don't take photographs, put these on social media, or take videos. Thank you. Now, we've got different definitions of obesity, and the World Health Organization definition is rather simplistic. It just says fat accumulation that presents risk to health. But the Lancet Diabetes and Endocrinology Commission, which in January of 2025 has come out with this definition: obesity, clinical obesity, and preclinical obesity. So obesity, they say, is accumulation of fat, excess adipose tissue with or without abnormal distribution or function of adipose tissue. So it could be intact or could have been dysfunctional. And that causes are multifactorial, and a lot of them are still understood. Please don't take photographs. Clinical obesity is a chronic systemic illness. Now, that's the second word coined by the Lancet Commission. Characterized by alteration of functions of tissues. So you move to the next stage where dysfunction of organs and individuals and combination thereof has already started. And then, like pre-diabetes, you have preclinical obesity, where you have adiposity, but function of organs and other tissues are preserved. But then the patient already has a risk of getting type 2 diabetes and other non-communicable diseases like cancers and mental disorders with obesity. The World Obesity Federation has added very important adjectives there: chronic, relapsing, progressive disease, and emphasizes the need for immediate action or prevention and control of this global epidemic. There is also a word very important, and we all realize it now: it's preventable, treatable, but relapsing. So we've got to keep all these adjectives in mind when you start seeing any patient with obesity. It's going to come back, it's treatable, it's preventable. In people who don't have problems, you could just prevent obesity if you have a family history. Now, here are some very important classification and measurements. We all know that BMI is just one tool to look at obesity, but it's really not the right answer. You know that athletes and people in the sports arena could have higher BMIs because of stronger bones. And so you're missing out on something, and you just label them as obese. So you have to have a waist circumference as a very important additional marker to diagnose obesity in conjunction with BMI. And also people who have higher cardiometabolic risk and who have lower BMI, the waist circumference is a very important issue, is a very important tool there. And these are the cutoffs which all of you are aware of. Asian Indians, men more than 90, women more than 80 centimeters would classify according to the waist circumference. But if you look at the BMI, The red box shows you the Asian cutoffs. So anything over 23 is overweight, under till about 22.9 is normal. Obesity class 1 is 25 to 29.9 in Asian Indians, but contrasted with the Caucasians, obese class 1 is 30 to 34. So we've got to be very careful when we are talking to our Asian patients. Now let me talk to you about pathophysiology and complications of adiposity. I'm going to spend some time making you understand this complex process of appetite control. Now remember that the brain and the hypothalamic region of the brain are really the monitors there controlling appetite. So you have a satiety center there and you have satiety hormones. Now there are 4 very important organs in the body which really throw out these hormones which reach the brain via the vagus nerve. The 4 organs being adipose tissue, the pancreas, the stomach and the intestines. Now let me just classify them for you. You've got 2 mechanisms there. One is called the homeostatic mechanism, which really gets you that appetite, the desire to eat. And you've got the hedonic or the reward system, which really controls the pleasure and displeasure associated with food. So you can see that word reward there. Now what happens when these hormones are released? So from this adipose tissue, you've got leptin. So there are 2 hormones. One is called the satiety group. The other is called the hunger hormones. Let me talk about the hunger hormones. So you guys will have this hunger hormone coming in maybe in 2 hours. So ghrelin is secreted from the stomach and glucagon is from the pancreas. So these are 2 very important hormones which stimulate your appetite. And then you've got this satiety hormones. Adipose tissue releases leptin, one of the most important satiety hormones. Then you've got PYY again from the GLP-1, both from the L cells of the intestine. And then you've got insulin, which is again a hormone which decreases appetite. So these hormones increase either hunger or decrease appetite. And they are the vagus nerves really takes care of sending these signals to the brain. I would also remind you of another very important hormone in the arcuate nucleus of the hypothalamus, which is called NYP. Now that is responsible again for energy storage, for appetite and other things. So it plays it's orexogenic and it plays a very important role in all this appetite management that you have. On the right panel, you see the expenditure part. So energy homeostasis is the balance between energy intake and expenditure. How much food you eat and how much you spend in the form of metabolism and physical activity. So if you see on the right, all of you know the basal metabolic rate. So that's the basic thing, energy requirement for body functioning. And that takes care of almost 50 to 60% of the total energy expenditure. Now there are 3 other terminologies there. One is called NEAT or non-exercise adipose thermogenesis. And that is for when you're doing your household chores or just walking to the office. That's not real physical activity. So that's NEAT. Then you've got TEF, which is energy related. And so you're walking or you're going to the gym, walking, and then that energy burnt is called TEF, thermal energy of exercise. And then you've got EAT, which is related to the food that you eat, and that is consuming. So this is total energy expenditure. So you've got a really balance between intake and output. Now what happens when you see these 2 adipose tissue? You've got the lean person, you've got normal functioning adipocytes. And then on the right, you see these obese adipose tissue. What has happened there? You've got recruitment of macrophages, inflammatory cells, and all this leads to distorted lipolysis, and really the free fatty acids flows out, and then this spills over into many tissues, not only the adipose tissue, but all the other tissue that you see here. So you've got type 2 diabetes and other complications. You've got liver, where you've got NASH, hepatic cell carcinoma, fibrosis, then you've got atherosclerosis and heart failure, hypertension, obstructive sleep apnea, and a host of other problems which I'm going to show you. So the basic difference is the adipose tissue in obese people has become distorted because of macrophage and inflammatory recruitment, macrophage cells and inflammatory markers there. Now these are the complications that you may have seen this chart a million times, the various complications of obesity, right from the central nervous system there, simple problem like migraine. And your patient is obese and you never realize that this migraine is probably because of obesity. Stroke, pulmonary problems, obstructive sleep apnea, so common, we miss it. So any person that you see with type 2 diabetes, obesity, ask for obstructive sleep apnea or work out that and try and find out. Pulmonary hypertension, nephrolithiasis. People just keep going to the urologist and forget they've got obesity. Genitourinary, urinary stress incontinence, PCOS, I think everybody understands that. Musculoskeletal, osteoarthritis. Then you've got depression and anxiety, and the world is facing this problem. Anxiety and depression, and you just prescribe an antidepressant drug there, forgetting that probably obesity is the answer there. Managing that, hypertension, coronary artery disease, stroke, atrial fibrillation, and then you've got these reflux problems, cholelithiasis, MAFLD, and NASH, and hepatic steatosis. Of course, you've got all these endocrine problems like diabetes, type 2 diabetes, dyslipidemia, cancer, infections. Now what happens if you make your patients lose weight? Just 10% of body weight loss can prevent diabetes. If you make them lose 5 to 15%, you'll probably be helping them reducing HbA1c, number and doses of your glucose lowering agents. All of us see when we use GLP-1s and the patient loses weight, within 4 weeks or 6 weeks, you've got to reduce antihypertensives, you've got to reduce doses of sulfonylureas and other things. Hypertension, obstructive sleep apnea, make them lose 7 to 20% of body weight and the OSA symptoms go away. And that happens when we use a lot of these GLP-1s. Patients come and tell you, my husband doesn't snore anymore. Dyslipidemia, NAFLD, steatosis. If you want to reduce fibrosis, you really need to lose 10 to 40% body weight, and you can see reduction in inflammation and fibrosis. Now let's come to the diagnosis and management. How do you diagnose this? Now this is a well-defined, this has data to show that this is an evidence-based strategy, the 5 A's. And this is exactly the method how you communicate with your patient. It's the HCP patient communication pathway. Never sort of start rebuking your patient that he's overweight. You've got to really indulge, take his permission to discuss weight. And then the patient feels comfortable. Otherwise he thinks, you're trying to insult him, that he's out of shape. So you've got to discuss and feel that the patient is ready to accept your advice. Assess. Now assess, all of us know we've got to measure all these BMIs and waist circumference and other parameters which would help you to look at obesity and associated problems that it may have. Advice. You've got to tell him, if you don't control weight, what is going to happen? The repercussions that I mentioned in my opening remarks, the repercussions of body weight. Agree. So you've got to talk to the patient and make him agree on some mutual goals. And this agree again is based on a SMART framework. The acronym for, you've got to really talk. It's measurable, it's advisable, it's timely or rewarding. So you've got to talk to your patient and give him advice so that all this is agreed upon, and then of course assist him with prescribing the right information and the right treatment that would help his problem, and all these things have to be individualized. Let's come to management. I think the most important part here is behavioral intervention. Psychological and behavioral intervention, probably in any chronic disease state, is of paramount importance. You just can't prescribe a drug for hypertension unless you tell your patients what to do with their lifestyle, their salt intake, and so on. And so this is exactly what you need when you're talking about behavioral intervention for obesity. And it's a continuous process. It has to go on every time the patient comes to you. You can't stop just with one session of behavioral intervention. It has to be all through the management cycle of obesity. Pharmacotherapy. Now that's the most attractive, and that's exactly what we want to do, and we tend to do at the first instance. Now people in this group of 25 to 26.9 may probably be benefited with diet, physical activity, which is a goal for everybody, all across all the BMI categories. But if you have adiposity related complications, even at 27 to 29.9, I think all of us tend to advise pharmacotherapy. And beyond that, I think everybody would need pharmacotherapy because, as I mentioned, obesity is a chronic disease. It's going to relapse. And I will show you in a minute why it relapses. It just doesn't happen because the patient gets his habits back. There is a physiological basis to that. Then surgery. Now, I know that it's a difficult suggestion to make to the patient, and the patient gets scared. But even at this level of 30, there are indications that you need to advise. But in Indians, I think we are going 30 is rather too far, and Jasjeet would agree, even in their hospital, 27, 28, 29, if with adiposity related complications, one would tend to at least talk to the patient about surgery. But remember, friends, all individuals, regarding of body size and composition, will benefit from lifestyle management. That is never to be missed, the lifestyle management. Lifestyle and behavioral interventions. Now, if you go and look at the details of this chart, these are 5 very important things, I think, which we tend to forget sometimes talking to our patients. Having adequate sleep, less of sitting, more of physical activity, and all of you who wear Apple watches, they tend to remind you it's time to get up and walk. And even stepping up your daily steps by 500 leads to a great advantage. Strengthening exercises are very important, resistance training, and all these people who lose weight after all these therapies really benefit with resistance training exercises. And sweating it out, I think that's the most important. And so use the lifts, use the staircase, and don't use the lifts. Be specific, be realistic. Don't start giving goals to your patients where you know his abilities to understand will not match what you are trying to convey. So you've got to be realistic, you've got to be individualized in your approach to these patients. Now, weight regain, as I mentioned in my opening remarks, is a very huge issue, and that's why the word chronic and relapsing is there. This is a very important study which was conducted in this is the enhanced data, 2001 to 2006, 2,500 people. 40% lost weight, more than 5%, 20% lost more than 10%. But data showed that within 2 years, 50% lost weight was regained. And within 5 years, 80% of this was back. You can see here 80% back. Now, why is this happening? I told you that we have these 2 hormone sets, one the satiety hormone and one the hunger hormone. So when you have lost weight, the levels of the satiety hormones have already dipped. So PYY, amylin, CCK, and leptin levels have gone down. And the hunger hormone has gone up. Levels increased. But the interesting part of the study was that even 12 months after the whole thing, these levels remained like this. So you can't blame the patient saying that, oh, he got back to his habits. There's a physiological reason why he's continuing to eat more. He started eating more. because these levels have gone back to their original levels. So the hunger hormone is up and the satiety hormones have dipped. And these adaptations are considered the physiological drivers of high rate of weight gain. So, and that's why weight regain is a huge issue. Don't blame it on the patient. It's a physiological answer to it. Pharmacologic therapy. Now, this is a chart which is very simple to read. I'm going to start here. Start medication. You've got to talk to the patient, discuss his access to all medications, start medication, but reevaluate medication within 3 to 6 months. Treatment goals not met, add or substitute another medication. Treatment goal met, continue the medication. And then reassess therapies periodically. The medications approved as of 2023 March in the United States were phentermine, topiramate, liraglutide 3 mg, naltrexone, orlistat 120 mg TID, semaglutide 2.4 weekly, and tirzepatide. Now, all these drugs mentioned in the top are not available here. Semaglutide 2.4 is approved but not available. Tirzepatide is approved and will shortly be available. So you've got to really treat comorbidities. You've got to really individualize these programs and percentage and durability of weight loss, keeping in mind the cost, the preferences, and the administration and tolerability of these molecules. Remember that bariatric surgery has to be individualized again, and the whole issue of bariatric surgery has to be discussed. I mentioned 27.5 as cutoff for Asian Indians. Sometimes you've got to really consider this. The programs showed here are the most commonly used, and probably we are not experts in this, but sleeve gastrectomy and Roux-en-Y gastric bypass are probably the most common bariatric surgery procedures, each having its benefits and outcomes. Quality of life and mental health benefits of weight loss. It's very important. I mean, we have seen this in clinical practice. Once the patient comes back to you with a weight loss of 5 kilograms, he's thrilled. The mood changes. His wife is happy, and so is he. And similarly, you find that bariatric surgery also is associated with post-operative decreases in prevalence and severity of depression. So it's a two-way cycle. You improve his weight, he gets happy, and once he's happy, he works more on losing more weight. So let me, friends, just summarize for you my talk. I said that obesity is a chronic, relapsing, multifactorial, preventable but treatable complication. It's a disease complex. Lots of these factors are still understood. It's the core principle in the holistic and patient-centered approach to care. You need a lifelong management because of the chronic nature and the regain phenomena that you see with obesity management. You need an early diagnosis, and that's crucial to preventing the health complications. You need a comprehensive approach, a multidisciplinary approach, which includes lifestyle, medical interventions, and you need a public health priority. I think the government needs to wake up and address this as a public health priority to reduce the burden on patients and the healthcare system. Thank you very much for